Hello, my name is Kevin Wei. I'm from Oregon Health and Science University, and today I'm here to discuss ultrasonic enhancing agent safety. I have a number of objectives that are summarized on this slide for this presentation. First, I will briefly review the composition and in vivo behavior of ultrasonic enhancing agents. Then we will review the benefits of ultrasonic enhancing agents in clinical practice. And finally, we will discuss the safety of these agents. There are currently 3 ultrasonic enhancing agents commercially available in the United States, and they are quite similar structurally. The DEFINITY microbubble has a shell which is made of phospholipids and contains a core of perfluoropropane gas. The LUMASON microbubble also has a shell of phospholipids, but contains a core of sulfur hexafluoride gas. The OUTPATIENTS microbubble has a denatured human albumin shell and contains a core of perfluoropropane gas. The shell helps to maintain the size of the microbubbles, and all 3 agents have a mean diameter of 1 to 4 microns, with 95 to 99% of them being under 10 microns in size. They are therefore small enough to pass unimpeded through the pulmonary capillaries. The high molecular weight gas in the core decreases the solubility and diffusibility of the agents in the circulation, allowing them to reach the systemic circulation after intravenous administration. After the agents are injected intravenously, they mix uniformly with blood and they remain entirely intravascular. This distinguishes them from the contrast agents that are used with CT or MRI, which actually diffuse into the interstitial space. The microbubbles possess the same rheology as red cells, which means that they flow through the microcirculation exactly as the red cells do. They are stable and non-toxic, and the shells are broken down by the liver, and the gas is excreted in the lungs. I would now like to discuss the clinical utility of ultrasonic enhancing agents as well as their safety. One of the early studies that evaluated the safety of ultrasonic enhancing agents in hospitalized patients was from Kuznetsky et al. In this retrospective study, 18,671 patients who had undergone echocardiography during their hospitalization were reviewed, and nearly 6,200 of these patients received DEFINITY as a slow bolus. This table shows the demographics of the patients who received DEFINITY compared to the patients who were considered controls and did not receive an ultrasonic enhancing agent. You can see that the patients who received DEFINITY were actually sicker. They had significantly longer stays in the intensive care unit. More of them had diabetes and hypertension compared to the control patients, and more of them also had COPD and CAD. These patients, therefore, not surprisingly, had lower ejection fractions. Despite being a sicker population, there was no difference in mortality between the groups who underwent unenhanced echocardiograms compared to those who had contrast-enhanced echoes. Michael Main subsequently did a much larger analysis involving more than 4.3 million hospitalized patients who had undergone echocardiography during their hospitalization. With this much larger power, he was actually able to show that patients who had undergone contrast-enhanced echoes were 24% less likely to die compared to patients who had undergone non-contrast studies. The reason why patients who undergo echocardiograms with ultrasonic enhancing agents have a better outcome was evaluated by Kurt from Bill Zogby's group at Baylor. In this study, nearly 700 patients with technically difficult studies were enrolled. The non-enhanced studies were considered technically difficult or uninterpretable in nearly 90% of the patients in this study. They included patients who were on the inpatient wards in dark blue, in the medical intensive care unit in light green, in the surgical intensive care unit in dark green, and in the outpatient echo lab in yellow. After DEFINITY was used, you can see that greater than 90% of the studies, in almost all cases, were considered adequate, even in the intensive care unit, with less than about 10% still being technically difficult. Practically none of the studies were uninterpretable after ultrasonic enhancing agents were used. The study was very interesting in that the investigators evaluated the impact of contrast use on patient management, first by giving the referring physicians the findings from the unenhanced echo study and asked the referring providers how they would manage the patients based on the information that they were given. Then they gave the referring physicians the results of the contrast enhanced study and asked them if the additional findings would actually change their management. As all of you know, the evaluation of left ventricular systolic function is the most common indication for an echo to be ordered. This slide shows that irrespective of where the echo study was performed, inpatient wards, medical or surgical ICU, or outpatients, that the use of an ultrasound enhancing agent shown in these green bars resulted in the detection of additional wall thickening abnormalities compared to the unenhanced studies, which are shown in the blue bars. The detection of additional wall thickening abnormalities was greatest in the most technically challenging patients, which are those patients in the intensive care unit settings. This slide shows the clinical impact of ultrasound enhancing agent use on patient management. The dark blue portion of the bars here show that the percentage of patients in each location where an additional procedure was avoided. The most commonly avoided procedure was actually a transesophageal echo. And in surgical ICUs, you can see that more than 30% of additional studies were avoided because an ultrasound enhancing agent provided the information that was necessary for the referring physician. The green bars show the percentage of patients who had a change in medications, for example, having an anticoagulant added because a thrombus was detected, or in yellow, where both a medication or procedure change was avoided. This slide shows the additional cardiac procedures that were avoided because an ultrasound enhancing agent was used for the initial echocardiogram. As you can see, the information available from an enhanced echo allowed more than 50% of additional TEEs or nuclear imaging procedures to be avoided in surgical intensive care unit patients. Avoiding downstream resource utilization by performing contrast enhanced echoes resulted in significant cost savings of the study. On average, $900 was saved per patient by using an ultrasound enhancing agent. Now that we have briefly reviewed the in vivo behavior of ultrasonic enhancing agents, as well as the benefits of these agents in clinical practice, we will now turn our attention to the safety of ultrasound enhancing agents. We will evaluate the safety in a number of different populations, including hospitalized, critically ill patients, the general population, patients with pulmonary hypertension, special populations including the pregnant women, those with intracardiac shunts, and children. And finally, we will discuss the very important but very rare anaphylactic reactions that can occur with ultrasound enhancing agents. This slide shows a summary table published in the Journal of the American Society of Echocardiography and shows the large number of safety studies published in patients receiving DEFINITY or Ultrasound since 2008. LUMASON was not available in the United States at that time, and I will show its safety profile later. Greater than 260,000 patients receiving DEFINITY and Ultrasound were evaluated in these studies. The echo studies were performed on both inpatients and outpatients and included patients undergoing both resting as well as stress echoes. To summarize the findings of these safety studies, there were no deaths or myocardial infarctions following the use of ultrasound enhancing agents, and there were no increased risks of serious adverse events, which are adverse events that require hospitalization after a patient receives an ultrasound enhancing agent. The incidence of severe allergic reactions was also found to be very rare, and I will go over the details of those findings in a later slide. To now look at the safety of LUMASON, this slide shows a study from Jelly et al., where more than 5,000 patients undergoing stress echo studies were evaluated. So all the patients in this study received infusions of LUMASON at baseline and at peak stress. 71% of the patients were men with a mean age of 64.5 years. And imaging in this study was performed with a continuous low mechanical index power modulation technique. This table summarizes the adverse events that were reported by Jelly. The most common adverse effects were headache and dizziness. Back pain reaction was noted in 1 in 200 patients, and arrhythmias were quite rare. Hypersensitivity reactions like rash or urticaria developed in 0.44% of patients. This slide compares the adverse events that are reported in the different package inserts of each agent. And what you can see here is that all three agents have fairly similar events reported, and overall, the agents are tolerated very well. Let's now look at some specific populations which are of particular interest for ultrasound enhancing agent use. First of all, because these agents are intravascular and pass through the pulmonary circuit, the effect or impact of the microbubbles on pulmonary hemodynamics is important. So the Food and Drug Administration required each contrastation company to evaluate the safety of their agents in patients with elevated and normal pulmonary pressures. The findings for all agents were identical, so I would just show the data for DEFINITY. In this study, approximately 30 patients, 17 of whom had mean pulmonary artery pressures greater than 25 millimeters mercury, were evaluated. All of the patients had hemodynamics obtained during right heart catheterization, and the DEFINITY was administered as a slow bolus. This just shows the different pressures and hemodynamics that were required at baseline and also after the administration of DEFINITY at multiple time points. The top panels on this slide show the time points on the x-axis and pressures on the y-axis. The top left panel shows the effects of pulmonary pressures prior to the administration of DEFINITY and at multiple time points after the administration of DEFINITY. You can see that systolic pulmonary artery pressure, mean pulmonary artery pressure, and diastolic pulmonary pressures all remained essentially unchanged at all of these different time points. The same is true of systemic pressures shown in this slide. Cardiac output and index are shown in the bottom left panel here, and vascular resistances in the bottom right panel. And again, there was no change in any of these parameters before or after the administration of DEFINITY. Next, we'll take a look at the risk of ultrasonic enhancing agents in patients with intracardiac shunts. This particular population was evaluated by CARPA et al. In a retrospective review of 39,000 echocardiograms, and 418 of these patients had an intracardiac shunt. So it is important to note that none of the patients had cyanotic congenital heart disease, and patients with only a left to right intracardiac shunt was actually excluded. What CARPA found was that no patients who had an intracardiac right to left shunt developed either a TIA or a stroke after receiving DEFINITY or Ultrasound. It was interesting that actually one patient who actually did develop a TIA was in the control group. So this patient did not receive an ultrasound enhancing agent. Next, we'll take a look at the safety of ultrasound enhancing agents in other special populations. Similar to most other drugs, the safety of these agents is really not available in patients who are pregnant, women who are lactating. But in animal studies, no effect was noted on the fetus in animals who were administered these ultrasound enhancing agents. In the pediatric population, again, for cardiac applications, the safety of the ultrasound enhancing agent has not been evaluated specifically. However, LUMASON has been approved for use in children for urologic procedures. So with all of this safety data available to the Food and Drug Administration, currently there is only one contraindication to the use of an ultrasound enhancing agent, and that is if the patient has a known hypersensitivity to the gas which is inside the bubble. So that would either be perflutrin or sulfur hexafluoride, or if the patient has a known hypersensitivity to any known component in the shell of the microbubble. There are still a number of warnings and precautions which are listed in the package insert for all of the ultrasound enhancing agents. So with the extensive safety data which is now available to the Food and Drug Administration, there are just a few warnings and precautions which are listed in the package insert of the three agents available in the United States. So apart from warnings about hypersensitivity reactions, there's still a warning about systemic embolization in patients with a cardiac shunt, although there is no longer any contraindication to using an ultrasound enhancing agent in a patient with a known cardiac shunt. There is still a warning that ventricular arrhythmias may be provoked when ultrasound enhancing agents are used during high mechanical index imaging. and a warning that serious cardiopulmonary reactions have been observed in patients, and that these usually develop within 30 minutes of administration. And we will be talking about these serious cardiopulmonary reactions very shortly. First, I wanted to discuss the phenomenon of back pain reactions, which develops rarely after a patient has received an ultrasound enhancing agent. As I mentioned earlier in this presentation, the incidence of back pain reactions is about 1 in 200 patients. This is data that shows why back pain reactions may occur after certain patients receive ultrasound enhancing agents. This was actually a study that was done in an animal model, and it comes from Jonathan Linner's group, and the study was performed in both wild type as well as complement deficient mice. They also used both agents with a phospholipid or an albumin shell. As you can see from these top left panels, contrast agents can enhance the cortex of the kidney, as shown here, and the degree of enhancement increases in proportion to the dose of the ultrasound enhancing agent which is used. What was interesting was that the duration of enhancement was actually quite prolonged, which means that these ultrasound enhancing agents are retained in the kidney. The fluorescent images shown in the lower left panels showed that these microbubbles are actually retained in the cortico-glomerular microvessels of the kidney. However, not all contrast agents will stick in the kidney. As shown in the top right panel here, microbubbles with a phospholipid shell would potentially be retained in the glomerular microvessels, but microbubbles with an albumin shell do not stick. Also, the microbubbles only stayed in these microvessels in wild type mice. In complement deficient mice, there was no adhesion of the microbubbles to the microcirculation, even when a phospholipid shell agent was used. So it appears that microbubbles with phospholipid shells can be retained in the glomeruli kidneys, which is actually a potential mechanism for back pain. The reaction is dose dependent, so administering less microbubbles, for example, using a dilute infusion rather than a slow bolus, should be less likely to cause one of these back pain reactions. Finally, let's turn our attention to the most serious type of reaction that can be triggered by ultrasound enhancing agents, which are anaphylactoid reactions, or the so-called complement activation related pseudoallergy, or CARPA type reaction. Now, one of the physiologic defense mechanisms that we all have against particulate matter, like bacteria, or in this particular case, microbubbles, that gets into our bodies, is the complement system. Complement can be activated either by the classical or alternate pathway after the complement encounters a particulate matter. And the activated complement then attaches to mast cells or basophils, which results in the release of a large number of these very potent vasoactive compounds that can result in a full-blown allergic reaction, which is the so-called CARPA, or anaphylactoid reaction. Anaphylactoid reactions can manifest just like a true anaphylactic reaction, including angioedema, asthma, bronchospasm, shock, and so forth. And if these reactions are untreated, could lead to death. There are some very important distinctions between anaphylactic reactions, which are mediated by immunoglobulin E, and CARPA reactions, which are mediated by complement activation. Firstly, the CARPA reactions may arise at the first exposure to the agent, whereas anaphylactic reactions usually require repeated exposures to the allergen before the reaction will appear. CARPA reactions tend to be milder or may even be absent if the patient is exposed to the microbubble again. Most CARPA reactions will resolve spontaneously, although they can still lead to serious complications. The treatment of CARPA reactions is summarized in this slide. For patients who have respiratory symptoms like bronchospasm, wheezing, coughing, and so forth, inhaled beta agonists are generally used. If the patient has skin manifestations such as rash, urticaria, or itching, antihistamines or H2 blockers can be used. And finally, for the patients who have the most severe type reactions, such as angioedema, hypertension, and shock, then the main treatment is intramuscular epinephrine. Intramuscular epinephrine is more effective for treating this type of reaction than intravenous epinephrine. So the incidence of CARPA reactions is very rare, and the actual incidence of these reactions in patients was established in a retrospective analysis that was done in nearly 80,000 patients who received DEFINITY or Ultrasound between 2001 and 2007. In this study, more than 10,000 doses of these agents were administered to patients who were considered critically ill or those who had acute chest pain symptoms. This data was collected retrospectively from 12 centers in the United States. Only DEFINITY and Ultrasound were included in this study because the data were collected between 2001 and 2007 when LUMASON was not available in the United States. This slide shows the demographics of the patients that were included in the study. As you can see, the median age of the patients was 59 years. Nearly half of the patients were male, and as expected, almost all the patients who received ultrasound enhancing agents had a high body mass index. This slide shows that a total of 8 hypersensitivity reactions that were felt to be probably related to the ultrasound enhancing agents developed in this population of nearly 78,000 doses of contrast use. Out of these 8 hypersensitivity reactions, 4 of them were considered anaphylactoid reactions. The anaphylactoid reactions therefore occur in approximately 1 in 17,000 or 0.006% of cases. Almost all of these reactions occurred within 30 minutes of exposure to the ultrasound enhancing agent. The incidence of anaphylactoid reactions to LUMASON is quite similar and is reported at 0.01%, although the total number of patients that is available is smaller. As I already mentioned, the mainstay of therapy for patients who develop shock or severe airway compromise during an anaphylactoid reaction is intramuscular epinephrine. So Michael Main has advocated having an allergy kit in the echo lab just in case a patient develops a severe reaction so that you don't have to find and break into the code card. And this slide just shows an example of the components that he would include in the allergy kit. And listed here is an inventory of some of the supplies, the medications that could be considered, the various supplies that would be included, as well as ancillary equipment such as oxygen. Now, just to put the risk of severe reactions to ultrasonic enhancing agents in perspective, this slide shows the commonly quoted risk of severe adverse events to some of the other common procedures that we do day in and day out in cardiology. For exercise stress testing, for example, we usually quote the risk of myocardial infarction or death at about 1 in 2,500. For bulimia stress testing, the risk of myocardial infarction or serious ventricular arrhythmias about 1 in 2,000. Iodinated contrast agents are also particulate agents that can result in anaphylactoid reactions. For high osmolar agents, the risk is about 1 in 500, and for low osmolar, 1 in 5,000. Gadolinium for MRI has also been described as potentially causing anaphylactic reactions at an incidence of about 1 in 10,000. And cardiac cath has serious complications occurring in incidence of about 1 in 500. And in comparison, anaphylactic reactions to ultrasound enhancing agents is shown to be no more than 1 in 17,000, and severe fatal allergic reactions at less than 1 in 500,000. So in reality, even though a lot of hype has been given to these serious reactions from ultrasound enhancing agents, you can see that compared to other very commonly used procedures, the risk of these agents is actually really very, very small. In summary, the ultrasound enhancing agents that are currently available in the United States include DEFINITY, LUMASON, and OPTISON, and they are very small microbubbles that can pass through the pulmonary microcirculation, just like red cells. Left ventricular opacification or endocardial border delineation using ultrasound enhancing agents offers many clinical benefits. They help to improve patient management, and they decrease downstream resource utilization, which helps to save cost. And the agents have been shown to be extremely safe in a wide array of patients. Rare anaphylactoid reactions, which has been shown to occur in about 1 in 17,000 patients, have been reported. And I also summarized the treatment of these reactions for you today. Thank you very much for your attention.